Hi, my name is Bob Macauley. I am the Cambia Health Foundation Endowed Chair in Pediatric Palliative Care at OHSU, and today we are going to be talking about how to act ethically in a pandemic, because some things are the same and some things are different. The opening graphic is a painting by Edvard Munch depicting an event during the last major worldwide pandemic about a century ago. And it goes to show just how difficult this time is as we grapple with some questions that we wished we would never have to face. One of the most important parts of ethical planning in a pandemic is to recognize that our duties have changed. In a normal world, the one we had before COVID, we would focus on individual patients. And so there were only two reasons why we would not provide a specific treatment. One is that if the patient or their decision maker refused the treatment, and the second is if the treatment was deemed not to be beneficial, which was a rather rare event. There are four core bioethical principles that we usually talk about. The first is autonomy, which in the old world was the preeminent one, whereby patients got to make decisions based on informed consent. The others are non-maleficence, or first do no harm, beneficence, or do good, and the last, justice, which is treating similar patients similarly, got a bit of short shrift, especially in a country that does not provide healthcare to all of its citizens or inhabitants. As the old saying goes, though, the difference is that was then and this is now. This is a map of the world based on COVID cases with larger circles revealing greater COVID prevalence. And as we all know, COVID has really hit some countries hard, in particular China and Italy. So whereas this was our approach in the pre-COVID world, our approach in the COVID world tends to focus more on public health ethics and prioritizing the health of the community over the health of the individual. So if we look at our four ethical principles that we had before, they really have become inverted in the COVID. Rather than prioritizing autonomy, we tend to more prioritize justice. And our focus is on the health of the community, whereas individual decision-making becomes less of a priority. There are various ethical duties in the pandemic. The primary one, in terms of allocation of scarce resources, is fairness, and the triage guidelines that we're going to discuss need to apply to all patients, whether or not they have COVID or are suspected to have COVID. There are also other ethical duties that are important in terms of stewarding scarce resources, and especially transparency, because for the public to have faith in a just and equitable health system, it is important to make sure that people understand not only what the guidelines are, but also the ethical underpinning for them. There have been a great deal of newspaper articles and discussions about what to do when we don't have enough to go around, especially when it comes to critical care and in particular ventilators. This brings up certain core components of any emergency triage situation. The first is to identify the degree of urgency or scarcity and to try to prevent the need for having to triage scarce resources. So the more that we can maximize supply and minimize demand, which is what flattening of the curve is all about, the less we will have to engage in this type of triage. It's also important in a triage situation to maximize the outcomes of the resources that we do have and apply the same criteria to all patients. Which raises the question of which criteria to use. Here's a list of 7, and I'd like to start at the bottom by identifying one that we shouldn't use, which is social worth. A bit of a backstory. The first time we really had in the modern world to deal with acute triage decisions for scarce resources occurred back in the 1960s. That was when dialysis was invented. And up until that time, if your kidneys stopped working, then you couldn't survive. But once dialysis was invented, it was possible to keep patients in kidney failure alive for a very long time. The problem was there wasn't enough dialysis to go around. So in order to allocate that scarce resource, there was a group of politicians and philosophers and attorneys and clergy who were convened to make that allocation decision, and they subsequently became known as the God Squad because they did take into account certain social worth criteria, including some that might seem somewhat outdated these days. Two criteria that they used for determining priority for dialysis were church attendance on Sundays and a history of participation in the Boy Scouts and Girl Scouts, which led a very witty commentator to remark that the Pacific Northwest is no place for a Henry David Thoreau with bad kidneys. In other words, we were prioritizing beliefs and convention as opposed to things that were more morally relevant. So if we eliminate social worth as a criteria, there are 6 remaining, and the one that pretty much everybody agrees on is likelihood of benefit. What this refers to is the probability that by providing a certain intervention, in this case critical care or a ventilator, will actually help somebody. So this is an allocation protocol from a widely cited article that grew out of statewide focus groups in Maryland. And what they identified was that people generally agreed that if you're sick enough to need critical care, that your priority should be higher if there's a good chance of you pulling through. And a SOFA score is an adult score for how sick an adult is. So if you are very, very sick and are unlikely to survive, even with critical care, you would get a higher point score. And if you are not quite as sick and are very likely to pull through, you get a lower point score, and the lower the points, the greater your priority. Another thing that many people take into account is not just the likelihood of benefit, but the extent of benefit. So here we have the scoring system that we just looked at, and if you add to short-term survival, here you have long-term survival, which means that even if you were to survive the acute event, you would probably want to prioritize people who could survive for a longer period of time and thus derive more cumulative benefit than somebody, for instance, who would be dying of an underlying condition even if they happen to pull through the COVID pandemic. As always, there are some caveats. One is that some scoring systems list specific comorbidities as exclusionary factors or as something that gives you extra points, which is a bad thing. And those comorbidities are often more common in certain underserved populations, which raises the concern for healthcare disparities based on access. And there have been a great deal of articles talking about incorporating longer-term survival as discriminatory against certain disenfranchised groups. Another consideration that many people have proffered is duration of the required treatment. In other words, patients who will only require, as best as we can estimate, a short period of time with a certain treatment should get a higher priority than someone who requires that treatment for a long period of time. This, however, is very hard to implement, in part because it's hard to know exactly how long someone will require that treatment, and the allocation guidelines are typically supposed to be implemented by independent triage teams, not the people actually taking care of the patients, which makes it harder to know from a chart review exactly how long someone will require that intervention. The next criteria to consider is what people will have referred to as the multiplier effect, which refers to the fact that for certain people, for instance doctors or nurses, if you save their life, then it makes it possible for them to save other people's lives. Again, there's a caveat, which is, will that patient recover quickly enough to help others, which in a prolonged pandemic like COVID is quite likely, whereas in other disaster situations like an earthquake, it may not make sense to prioritize healthcare workers because by the time they recovered, the emergency may have passed. Another concern people have had in terms of implementation is where to draw the line. Certainly doctors and nurses are important, but so are respiratory therapists and hospital administrators and truck drivers who deliver critical supplies and are necessary for the functioning of the healthcare system. So if you grant that the multiplier effect should be considered, it's not entirely clear who qualifies under that. Reciprocity is also an important principle. The idea being that if you risk your life to help others, shouldn't society repay you by prioritizing your treatment if you get sick? The problem here is that since healthcare workers are on the front lines and are perpetually exposed to COVID, it runs the risk of only healthcare workers getting critical care, which doesn't seem fair. And the last consideration, which has prompted, again, a lot of debate, is what they call the life cycle approach. According to this, there are certain cycles in life: infancy, childhood, adolescence, adulthood, middle adulthood, elderly, and the idea is that everybody should have the same chance to go through all those life cycles. So a 70-year-old has had a chance to go through several, a 7-year-old has had a chance to go through few, so a younger person should get the priority. To be clear, this is not prioritizing purely based on age, and not breaking it down so narrowly that, say, a 35-year-old would get priority over a 36-year-old, but rather based on the stages of life. This has led to accusations of ageism and discrimination against the elderly, which I think is true if you were to exclude from consideration people over a certain age, as has been done in certain countries like Italy, but this is not what we're talking about in terms of trying to guarantee people an opportunity to live through the life cycle. So thank you very much for taking part in this presentation. I wish everybody safety in these uncertain times, and my hope is that we never have the need to implement these triage protocols, but that if we do, they will be thoughtful and transparent and try to help as many people as possible. Thank you.